either sinus or nasal pathology. So out of these, 83% had sinusitis, while 17% other people had non-sinus rhinogenic headache secondary to deviated nasal septum or infectious causes like vestibulitis. So history of nasal obstruction and discharge can also be a presenting complaint in case of migraine due to autonomic nervous stimulation. Therefore, these symptoms do not necessarily indicate sinusitis. So 66% of our patients had chronic headache, some of them as long as 25 years. So in this chronic headache, the most common cause was found to be sinusitis followed by migraine. So there was no statistically significant finding between the duration and the cause of headache. So patients usually consume over-the-counter medications for pain, or they consult other specialists like chiropractors or physical therapists for this headache. So this could explain why they have been having such a prolonged headache in this study. So those patients who are not found to have primary headache or rhinogenic headache, they were sent for ophthalmology, neurology and psychiatry consultants. Out of these, 3% were found to have refractive errors and 3% were found to have somatoform disorders. Neurology reference was sent in 6%. So in these patients, 5% of them did not have any findings on MRI. 2% of the patients were diagnosed to have headache secondary to hypertensive crisis. All of these were women in late, that is 7th decade of their life. So our aim as otorhinolaryngologist was to assess, triage and treat patients presenting with headache based on any headache with or without a causal link. A thorough comprehension of the latest guidelines and multidisciplinary team approach is essential in recognizing and treating the headache disorders and delivering a better health care. Thank you.
Thank you.
I am Dr. Monali and I am going to present a rare finding that we had. Sensory nerves, cranial nerves or autonomic nerves. So in the head and neck region, an ENT surgeon would find that 25 to 45% of all schwannomas present in the head and neck region. But in this, only 1 to 2% are intraoral in origin. So this is very rarely seen in the palate. Coming to the demographics, it's commonly found in the 2nd and 3rd decade with varying gender distribution. They may develop centrally within the bone or within the nutrient channel, causing hypertrophy in the bone. A periosteal or soft tissue tumor may erode the surrounding tissue and penetrate the bone, but rarely obvious erosion is seen in the bone. So coming to what we encountered, a 50-year-old male who came with an insidious growth on the roof of his mouth about 7.5 months back, and it rapidly increased in size for a few days and then stayed constant. He didn't have any complaints of pain over the swelling or any discharge. So it was just a mass in the mouth that was bothering him while eating. On intraoral examination, we found a swelling which was about 3.5 into 2 centimeters on the anterior hard palate on the right side, and the mucosa over it appeared normal. The mass was fixed, uniformly cystic in consistency with well demarcated margins. He had no cervical lymphadenopathy. 10 years back, he had an unrelated incident of ischemic heart disease. So we worked him up for surgery, and this was the initial pictures of the presentation of the mass. So there were no other signs of bony erosion, any disruption in the mucosa, any ulceration. It just was a smooth swelling in the hard palate. So he had also come with CT images from an outside clinic, which reported the mass as a well-defined soft tissue attenuation lesion in the roof of the mouth, measuring 31 into 10 into 13 mm with scalloping of the hard palate and maxilla. But there was no evidence of fat or calcification, a non-enhancing lesion. Reportation, we did not find any discharge, any necrosis, any cystic fluid. So then we sutured the remaining mucosa, just simple, and gave a pressure dressing, and eventually on follow-up, it healed without any other requirement for support. So then the mass was sent for histopathology, and they described it as a well conclusive, or they needed further investigation. We should have gone for immunostaining analysis for S100, which is significantly positive for neurolimomas. So immunohistochemistry is the final diagnosis. They also exhibit positive for proteins such proteins in glial fibrillary acidic protein, U7 antigen and vimetin. So the take home message would be that even though it is very rare, it is one of the diagnoses when we are presented with what appears as a simple mass which is well circumscribed, fleshy and firm, but not eroding the bone on radiological examination, because the prognosis with just a wide local excision is almost.
So lateral nasal flap was elevated and the drilling was done over the frontal part of the maxillary bone, and complete nasofrontal beak was removed, and the frontal recess was seen, and the frontal recess was completely obscured by infected bony wax, which was, I think, completely occluded during the previous brain surgery. It was further widened, the nasofrontal beak was completely removed. This was to achieve space for my instrumentation to completely remove the infected material in the frontal sinus. You can see that the pus was coming on external compression from the infected bony wax, which is completely lining the frontal sinus from the lateral wall and also from the roof. The multiple bone wax particles were thoroughly removed till the normal mucosa was achieved. The mucosa was not removed, and the neurosurgeon previously has he packed the frontal sinus with bone wax, which completely got infected and also blocked the ventilatory pathway of the frontal sinus. So there was, after removing the thing, complete anterior posterior ethmoidectomy was done, sphenoidectomy was also done, and also there was multiple granulation tissues seen after removal of the bone wax that was also debrided till healthy mucosa was achieved. A merocil packing was done, and also the flap was repositioned back. So briefly, what like I described, left anterior posterior ethmoidectomy was done after completely removing the frontal sinus pathology. Thorough nasal washes were given, and hemostasis was achieved. And a merocil small packing was done, and gel foam was placed over the raw area, and the mucosal flap which was removed was repositioned back. And the post-operative period, the patient received antibiotics for 1 month, oral steroids for a week, and nasal douching was advised for a period of 3 months. Periodic weekly and monthly endoscopic nasal cleaning was performed, and 6 months post-operative period. You can see that this was on a 0 degree endoscopic view, in which a wedge resection of the middle turbinate was done, and the frontal recess was completely pated, and there was complete nice mucosalization, and there was no granulation or any pus or any discharge accumulated seen. This is on a 70-degree endoscopic view of the frontal sinus, including the roof, which was the primary source which was infected and was the source to the sinus formation. So the frontal sinus is approached inappropriately during craniotomy. The lining mucosa is injured, determining the blockage of the frontal recess, and it can generate sinusitis. What it leads to is pressure necrosis of the walls of the frontal sinus and osteitis, and also subperiosteal abscess, which removes the periosteum from the bone and results in a fistula formation. Mucosal reepithelialization, ventilation and drainage can only be achieved if the frontal recess remains patent. Despite intraoperative injury of the frontal sinus and infections, the complications are rare. Hence, we see these fistulas in a very rare manner because at least a bit of frontal recess patency is achieved on a normal basis. However, if the frontal cutaneous fistula is formed, the management by underlying pathology, by removing the underlying pathology, and also properly achieving ventilation of the sinus involved only treats it completely. In the previously mentioned data, all the cases were managed by external approach, but this was a case in which we completely approached through endoscopic manner, and after 6 months of follow-up, the fistula healed really well. Thank you.
But it has a propensity to invade into bone, resulting in sclerosis, mass formation, and bone destruction. Gradual onset, usually more than 12 weeks. So the objective of this study is to emphasize the diagnostic challenge of chronic invasive fungal sinusitis, which mostly mimics the sinonasal malignancies. So materials and methods. So inclusion criteria, patients who had nasal and eye complaints were taken, and also immunocompetent patients. Exclusion criteria, of course, comorbidities and immunocompromised patients. So coming to the case scenarios, patient's consent was obtained. So this was the first case. So he's a 62-year-old male patient, came with complaints of infraorbital swelling on the left side in 6 months. So as you all can see, there is a 1 into 1.5 swelling well circumscribed near the medial canthus in the inferior part. So diagnostic nasal endoscopy was done, which just showed fullness in the uncinate area. So MRI was done, which showed an irregular march in the left medial canthus, which was eroding the nasolacrimal canal and posteriorly extending up to posterior lacrimal crest, suspecting of a lateral nasal wall tumor. So intraoperatively, we did an external medial maxillectomy, and the entire tissue was taken out along with the lacrimal sac and sent for histopathology, thinking of malignancy because it was eroding, but it came out to be a granulomatous inflammation resembling a hypomycosis. This is the second case. So he is a 54-year-old male patient, came with complaints of protrusion of the left eyeball for 3 months and diminution of vision in 2 weeks. No comorbidities, but he was a smoker. Diagnostic nasal endoscopy was normal. So CT was done, which showed a soft tissue density in the left retroorbital region, which was extending up to the apex. Also, it was involving the pterygomalta and fossa, inferior and superior orbital fissure, and medially into the left frontoidomized sinus, and lamina papricia was breached. So this was with navigation. So neuronavigation was done during the surgery, and a biopsy. So patient underwent endoscopic biopsy. So as you all can see, there was proptosis, and this entire tissue was removed. And it was sent for histopathology, which showed aspergillosis. So this is a third case. So 42-year-old male patient came with complaints of fullness in the left side of the nose, and he also had one episode of epistaxis. So DNA was done, which showed a yellowish mass in the medial left maxillary sinus. So CT was done, MRI was also done, which showed erosion of the lamina papricia, and endoscopic biopsy was taken. This we suspected it could be a schwannoma, but again it came out to be a aspergillosis. So coming to the discussion,